Hello, everyone. Welcome and thank you for coming to this webinar. I'm really happy to be here as usual. We are going to talk about the orthodontic principles that will influence the planning with aligners. It's very important to understand um, the the in the way we plan cases and what elements we consider for this planning, as not every single approach will be exactly the same. Not every single patient will present the same clinical conditions. So it's important to touch base on the elements that will um, influence these decisions. As you know, the orthodontic world has seen a digital revolution with the implementation of aligner therapy. There's many elements that the digital world has brought into the orthodontic world, good and bad, but it's definitely make a huge impact on the prediction of, for example, the prediction of final positions, but also the provision of individual control of movements, which is different to what you normally would see on orthodontic appliances that are not subject, or they're not based on a digital creation or a digital file, digital software that will move teeth. So this will, of course, provide an element of prediction and individual tooth control rather than following just an arch wire. So it's very, very good to consider that. The aligner capabilities, well, it's obvious that if you have done, or if you're in contact with orthodontic appliances, you will see that the gap between braces and aligners is getting smaller and smaller. In other words, everything that you can achieve with a fixed appliance, pretty much you can achieve with aligners now. This is due to the fact that aligners, obviously, as they mature and they get, we do more and more cases and understand the mechanics that control the movements correctly, will become more and more efficient when doing or virtually treating all malocclusions. Obviously, another advantage is that this appliance, or the provision of this appliance, it's available mainly to all dental professionals, to a degree, of course, but it's not just limited to specialist orthodontics. In 6 Months Smiles, we have put all of this knowledge and skill together to develop an aligner that follows predictable and realistic movements, to deliver, of course, a functional yet aesthetic approach to all of the cases that you submit. So it's very important to keep that in mind. Okay, so how does this process of planning cases look? We have four main elements, or four main categories on the workflow. We're looking at the 3D analysis that involves the digitize, or the scan of the teeth, digitalizing the patient, cloning your patient digitally, as I always refer to. The segmentation and the setup. We'll look at this in more detail in a second. We have the case design. Within this category, we'll look at the biomechanics of the tooth movement. We'll consider the clinical conditions and the future align the stages and quantify the movements. From then, obviously, it's very related to the sequencing of the orthodontic movements. We look at different approaches, or different order of movements, whether it's torque, rotations, angulations, etc. In this case, we'll also look at the parameters of predictability, the staging of the IPR to perform it in the best possible way, and not to prescribe or perform unnecessary amounts of IPR. And then also features like attachments, placing attachments, and when and how and the best for that particular um, movement. Then we move into the production. On the production side, obviously we look at the 3D printing, the stages, and the liner pressure forming, and we use robotic trimming or 5-axis trimming, so there's less human error on this way, and then laser marking and polishing for the best approach for your aligners and the best quality. Let's look at the 3D analysis. Here we're going to look at how the digital models are analyzed, segmented, and set up for a case planning. Basically, from a scan, whether it's an intraoral scan or if you take a PVS impression, as in analog impression, and we digitalize it, we need to tell the software what mainly what are teeth or hard tissues and what are gums and soft tissues. And within that, we want to indicate in the software what areas need to be taken into consideration. For example, what is an upper right 6, what is an upper right 5, where does it start, where does it end, and more importantly, where the long axis and the angulation, the correct angulation of the teeth is. These might seem obvious and simple, but it's in fact the most important aspect before planning, before moving teeth, because if the information is incorrect from this step, all the movements will be wrong and the forces will be delivered incorrectly. So it's important to have a team, which we have, of experienced providers or performers of this digitalization and segmentation and indication of where the correct positions and landmarks of the teeth are. Otherwise, everything will not work as we would like to. Moving on, we look at the case design. Here we're going to see how the biomechanics of the tooth movements as well as the patient's clinical conditions will influence the future of the aligned state of the case. Basically, we want to design or assess where the final position should be, considering the clinical conditions that the patient presents. It's important to understand, first of all, the biomechanics of the tooth movement and how we will be predictably moving teeth. And mainly, we will do this by controlling the forces that move them. Of course, it's very simple to say that, but it's important to understand how we control these forces. And for that, we need to understand that we're working with a tooth organ that has areas of compression and areas of tension when a tipping force or any type of force is applied, and these will be around a center of resistance or a center of rotation, which is located somewhere around the root of the tooth. As we understand that, we see that whenever you apply a force, and these forces of these areas of compression and tension will release a cascade of cells in the shape of osteoclast and osteoblasts. So whenever you apply a force, the periodontal ligament gets compressed. Obviously, the osteoclasts will be coming into this area to create the space where the tooth needs to move into, and the periodontal ligaments that get stretched, they will release a group of osteoblasts to create a buildup of bone to fill the gap where the tooth is moving from. So that's the way it goes. As you can see on the video, this is an illustration of these cells moving into the bone to remodel it where we need the space and build it up where we need to fill the gap, basically. What about the aligners? We work with a plastic, and when a tooth is moved by aligners, the forces acting on it are evoked by reversible deformation of the aligner in various ways. During this deformation, the aligner tends to lift up from the teeth or move away. Obviously, for every action, there's an equal and opposite reaction. Um, so whenever we work with this, we need to understand that the forces, occlusal forces, or anything that we place with the aligners will help us direct these forces correctly. And it's important to know that the features implemented into the aligners will help these forces and will help um, direct in a predictable manner these aligner positions and these aligner forces. These understanding the movement or the forces and the interactions that you have with the teeth and the forces that are applied to the teeth by this plastic will take us to the best combination of gentle and continuous forces for better orthodontic movements. And this is important because you can move teeth with anything. Basically, any appliance can move teeth. But the difference is that the orthodontic paradigm tell us that moving teeth in a controlled manner will avoid resorption, and that's what we aim for. We aim for a controlled movement, predictable movement, without being too aggressive, and that is one of the beauties that we can achieve and we can provide with clear aligners. Forces that are controlled, directed, and decided by us and the digital planning without creating a resorption or any iatrogenic results. So that is the important element. We have plenty of ways of understanding these forces that interact. As you can see on the illustration, you see the placement of attachments will definitely benefit the control of the crown and the root movements on these forces, and will interact with the aligner to provide these forces exactly and direct these forces exactly where we want them, all with the aim of achieving the movements that we predict on the software. It's important to understand that it's the skill that the planner of this case has, and the algorithms that we implement on the appliance that will provide this. Because the software, obviously, if you move a tooth from I don't know, an upper left 3 into the position of an upper left 4 and super rotated, of course on the software you will see that it will be moved. But the reality is that if those principles of movement are not applied, the tooth clinically and in reality will never move as you see on the digital world. And that is the main challenge that anyone that begins the journey with clear aligners will quickly realize that the virtual world is not necessarily what you will see in reality. So it's important to get this skill or use a company like Six Month Smiles that has the skills to predict these movements, or to provide movements that are only predictable. Let's look at the clinical conditions that will guide or will make a variation on our planning. So when designing an aligner case, we must consider the patient's chief cosmetic complaint and clinical conditions. These will influence, or that might influence the case outcome, whether they're periodontally compromised, or if there are any enamel issues, bruxism, in need of extractions, any TMJ symptoms or disorders, whether the patient has a considerable sensitivity of the teeth, any airway constrictions, missing teeth, any implants that exist. Obviously, we won't be able to move implants, or any orthodontic appliance cannot move implants. I think that's pretty obvious, but I I think it's good to mention. Canine and molar classifications, obviously, if we want to maintain or modify, and very, very, very important, before any orthodontic treatment is done, we need to consider any future restorative treatment. So we move the teeth in the correct position according to the restorative plans that we have. So yeah, it's important to consider all of these elements. Additionally, we need to look at the shape of clinical crowns. The success of movement or the predictability of movement with aligners is very or directly related to the size and shape of the crowns, because indifferent to the fixed appliance, there's nothing bonded to the tooth. So the way we will be able to control the movement of a root, because obviously we move crowns and roots in orthodontics, it will be the shape and the size of the crown. So if we have peg-shaped laterals or very small incisors or in small teeth, we will need to consider this when planning the case. We need to make reservations or modifications to our plan when we have this, because it's a factor that is against our predictability. The length and anatomy of the roots, obviously, they can be quite challenging, difficult to know if you don't have a radiograph. And then obviously the age of the patient and the bone density, which is related, more mature, sclerotic, and dense bone will be more challenging. So the older the patient is, the more slow the movements and the cellular process will be. So that can be translated to more refinement. So we need to consider that. So, and perhaps when if we consider to move, I don't know, 45 degrees of a rotation or start moving teeth distally on a young patient, our plan will be modified if it's an older patient. Perhaps we want to be a little bit more conservative, because you don't want a patient basically to wear aligners for a very long time if they're not if the movements are more challenging. So it's important to consider all of these conditions when we have issues that will affect directly the predictability. So even after a complete assessment, obviously there are a lot of interventions that we have to do as clinicians. What is the best for the patient? Do we need to treat this patient, or perhaps a referral? It's better. It's always good as general dentists to let the patient know that there are specialists that can also offer this treatment, and that you're not a specialist, and a referral is always available if they want to have a second opinion. If you treat it, what should we address? What should we leave out of this plan to restore it or not? Perhaps one of the elements that patients do not consider when looking at teeth alignment is that orthodontics will only move teeth. And I always joke with patients saying, if you have ugly teeth, we will align your ugly teeth, but your teeth will remain ugly, in a very jokey manner, of course. And what I'm trying to say is that if the teeth are chipped or worn down, we will align them, but the aesthetics will not be improved massively unless you plan a restorative work after the orthodontic treatment, after the teeth are aligned. On the flip side, there are patients that once the teeth are aligned, they're super happy and they don't even care about composite or veneers anymore, or even whitening. As you align teeth, you get rid of all the shadows, and the teeth suddenly become whiter because there's no the light hits the teeth in a better way. So it's important to consider both all of the conditions. On this case, when you present or when you have a patient with spaces, we need to consider whether we are going to close the spaces if the clinical condition is favorable for the closure of the spaces, or if we want to restore. On this particular case, I think it's best, obviously, not to close the spaces. In fact, perhaps to um, refer the patient for an orthodontic assessment. Orthodontically, obviously, well, his second molars have not fully erupted, um, so it will be difficult to have a real contact or a real occlusal relationship. Um, there's a lot of discrepancy or skeletal discrepancies, and when you submit these to us and we can assess it, we will advise you on whether to treat or not. So um, this this is not an analysis that you can get from a computer or a technician. Is something that needs to be assessed by professionals, and that's what we offer. Um, at 6 Month Smiles. So we advise in this case to seek comprehensive ortho guidance and refer, basically. So that's the advantage of working with professionals that will give you the correct advice. Okay, let's look at this case 3. Patient obviously wants straight teeth, as they all do. There are a couple of different approaches we could take here. Obviously, the AP relationship is an obvious class 2 with an increased overjet. If the patient wanted to reduce fully the overjets and correct if we wanted to correct the AP relationship, obviously we'll have to distalize the posterior segment into class 1. It will be quite challenging. So in this particular case, the patient decided to align the anterior segment. Obviously, we have the advantage of root control attachments, and that will help us upright the roots of the centrals and give a better alignment without too much of the posterior segment interaction. We have not created any traumatic occlusion, so the posterior relationship remained, but we were able to deliver a good anterior alignment with addressing the vertical plane, the sagittal plane and the transverse plane on the anterior segment, giving the angulation of the teeth in a better look. This case 4, doctors requested level and align. Obviously very limited instruction, but if you look at the patient, has a very retrocline lower incisors due to the class 3 skeletal and tendency that the patient is presenting. So alignment of the lower anterior segment will immediately collide with the upper arch. So it will be very tough to achieve this. Perhaps a bit of expansion will help the posterior segment, but it will be difficult to treat both arches with with clear aligners. I think upper anterior segment, it will be able to be aligned, but the lower arch, we're looking at a more comprehensive approach. So possibly not a great case to treat. When we plan the cases, obviously we quantify the movements. We look at all the collisions, all the interactions between teeth, and we produce specific values and guidelines that will ensure the predictable movements throughout the therapy to achieve this final position. Let's look at the sequencing. We need to understand how orthodontic movements are sequenced and how factors such as parameters of predictability and aligner material will influence these movements. When planning the sequence for an aligner case, a sophisticated biomechanical approach is used. we ensure safe and high predictable all movements are planned, no unrealistic movements, which is very, very important, and use of features to further help increase the predictability of movements like attachments, power bars, and pressure sports. Um, we have to consider whether we work with favorable and unfavorable movements. So, for example, if we are about to correct a crossbite, whether this crossbite is a straightforward expansion or buccal flare of the posterior segment, and once that's achieved, we're not going to end up with a cost-to-cost relationship, as we will consider this favorable. An unfavorable crossbite is exactly that, when we have to modify not only the transverse plane but also the AP relationship or the sagittal plane, which will make this more difficult and more unpredictable. Certainly more of a thorough approach, more comprehensive orthodontic approach, that will definitely take more than 20 aligners. So we need to look at this when sequencing and when correcting the clinical condition. Also, for example, another case or another clinical condition that it's very common is when you have a retrocline upper incisors. It's important to correct the retrocline position before intruding, for example. Otherwise, you will have an issue when trying to correct a deep bite if you don't upright the retracted or the retroclined upper incisors. For example, some errors that you find on digital plans is when unnecessary movements or unpredictable movements are prescribed. As we see on the premolars, upper left 5, there was an excessive mesiodistal root torque on the premolar, which not only leaves or modifies worsens the position or the mesial tilt that the crown should have, but also will mean that the root has to move through the bone mesially, which is unnecessary. Lower incisors, instead of doing excessive protraction, that will increase the risk of recession. Obviously, the roots can be thrown through the bone buccally. It's important to consider the need of perhaps intrusion and retroclination instead of that. So it's important to look at these different movements and the correct approach. Is not all movements applied to the same patient just for alignment. It's difficult to see that on a digital model without considering everything else. The other common mistake is when you see digital plans, going back to the challenge of the digital world, that everything looks amazing. As you can see, movements that are unpredictable on treatment plans that you don't really spot, or you don't really see, like this third molar moving. I mean, that will never happen. And this is an actual case that was approved and from other aligner companies, and obviously that will never happen. Even with the best fixed appliance, will be very, very difficult, very unpredictable. So it is not an ideal scenario, but it's important to understand that constant monitoring of predictable movements is part of your aligner journey, and that's what we predict, what we provide. Let's look at this example of incorrect sequence. The lower left 1 correction creates a collision with the lower left 2 if the movement is programmed simultaneously. So on this particular case, you need to sequence, or the movement is to be approached in a different way. And normally, if you don't understand this concept, companies will just provide a lot of IPR. So so you can actually rotate that tooth. But the correct approach is to create the space by perhaps expanding and proclining and then rotating the tooth lingually. It's very easy to quickly start every single movement and then create collisions, which will not be ideal for the predictability and also the well-being of the teeth. Same for the upper left one. It needs to be placed out to create space for the upper left too, and to procline without the IPR, instead of bringing just the lateral forwards with IPR. It's a little bit of round tripping, if the conditions are ideal for it, can be done, and the IPR can be completely reduced. Let's look at parameters of predictability and what we work with. We work with different parameters of predictability when we're looking at different movements. So, for example, for proclination and retroclination of the incisors, we do about 35 to 40 degrees of buccolingual retroclination and proclination, obviously, for incisors and canines. The mesiodistal root torque on incisors and canines is between 15 and 20 degrees. That means moving the root mesially or distally through the bone when needed. That will help. That will be help with root control attachment. Then we have the anterior rotation up to 40 degrees, 30 to 40 degrees of incisors and canines. For canines also we will need an attachment, as well as for the premolar rotation, which is up to 35, 40 degrees as well, with 20 aligners. And then extrusion, looking at the vertical planes, extrusion and intrusion of incisors and canines, anterior intrusion up to 2 millimeters, for extrusion of premolars up to 1 millimeter, and for intrusion of the incisors up to 2 millimeters as well, but the premolars around 0.5 of a millimeter. That's what we will have as a predictable movement. Lingual root torques or palatal root torques, when have retrocline incisors, we're looking at 15 to 20 degrees. Please note, this is not proclination. This is actually the root or the apex moving through the bone palatally or buccally. That's what we have as a predictable movement, 15 to 20 degrees. On predictable movements, we're looking at premolars moving mesiodistally, the roots mesiodistally. It's quite unpredictable because the size of the roots are quite big. Posterior extrusion or intrusion of more than 0.5 millimeters is quite unpredictable. And posterior crossbite correction, unfavorable crossbite corrections are unpredictable. That's important to consider. So on a sort of parameters of treatment time, when planning for 6 months smiles, the amount of movement can be achieved within these parameters, as you can see on the table. So it's a ballpark sort of amount, so you get an idea. The crowding 7 to 10 millimeters, space 5 to 7, but that's also depending on the clinical condition. Not all the space cases will do that. Some more, some less, some none, because of the tooth size discrepancy. As we said, rotations 35 degrees I think is better. Intrusion, extrusion per tooth, 2 to 2.5 millimeters, and posterior intrusion 0.5, and basically the same values that we looked at previously. Looking at features of predictability, it's obviously very important to talk about attachments. Attachments have a contrast of opinions and likings within patients and providers. The reality is that attachments are key to achieve movements predictably, mainly because we work with an appliance that obviously is a closed system that is in contact with the crowns but is not bonded to the crowns. So when trying to achieve certain movements, for example extrusion on incisors, will be quite tough to achieve it without changing the shape of the incisors, because the aligner will just slip off as they try to pull the incisors down in terms of extrusion I'm talking about. So it's important to consider that certain movements on certain teeth will be more challenging without changing the shape. And to change the shape of the teeth and to improve this predictability, we create attachments. And we have extrusion attachments, rotation attachments, root control attachments, and anchorage attachments. The extrusion attachment, as I mentioned, is to achieve the incisor and also some of the posterior teeth extrusion by changing the shape. So the aligner will engage onto these surfaces and will pull the teeth into the correct position of extrusion or extrusive movement. Rotation attachments mainly done or mainly placed on round teeth, as the flat or incisor teeth shape is more favorable for rotation without attachments, most of them. But the round teeth like cuspids or bicuspids are more difficult to rotate without attachments. So for that, we place rotation attachments. The root control attachment is also important because, as I mentioned, the aligners are not bonded to the teeth. So moving the roots mesiodistally or mesially or distally through the bone will be more challenging without this feature that we provide. And then finally, the anchorage attachment. That's basically the only attachment that is placed onto a tooth that doesn't necessarily have to move. In other words, these are only attachments that will provide enough retention to intrude, for example, the anterior segment. So the anchorage attachment will be placed onto premolars on the left and on the right-hand side to intrude the anterior segment, and that they will provide the retentive forces for this movement. Finally, we'll look at the production sequence very briefly. This is how your aligner cases are produced using state-of-the-art technology. This is not a little lab, being or doing things manually. It's a workflow that uses the best 3D printers on the market to provide the best accuracy on the models that are provided by you, or the scans after being digitalized, sequenced, and planned. Then we send it to the manufacturing process, where firstly they will be digitalized, then 3D printed. Every aligner will have a model that will have and predict the movement, so we'll be replicating the movements 100% accurately. Once the models get with the best plastic, get the pressure formed, they get into accuracy code directed to your patient's details, to then go into a machine to be automatically trimmed. This obviously reduces the human error because it's a machine trimming them, and the manufacturing issues should be reduced, and the quality, of course, of the trim and the smoothness of the align trimming edge, it's superior. So it's a great machine to have. Then they get also laser edge and laser marked, with all your patient's details. So obviously the branding and the aligner number, which is very, very, very good. That is the production line in a nutshell. Everything is obviously with the aims of providing the best quality aligners for you and your patients with a less risk of any manufacturing issues. However, there's always exclusions to the rule, but fear not, any manufacturing issues for any reason will be replaced, and in a very promptly manner. So I hope this presentation has given you an idea of how we approach your patients' cases in a very skillful and professional way. I hope this has been cleared. This has been clear enough and instructive enough. But I will obviously welcome and would like to answer any of your questions. Thank you very much.
Hello, good afternoon, good evening, or good morning, depending on where you're joining us. Thank you for participating in this presentation. The first question that we have is, who is the planner? Does it work? And does the system work on Bruxers? So the planners are highly skilled orthodontists that have had a significant training on planning for aligners, including to being a orthodontist. And yes, the aligners do work on Bruxers. There are limitations, it's case dependent on how much we can move teeth when they have suffered wear due to bruxism. And that's all case dependent. We'll be glad to see your case and then advise you as such. The second question is, can skeletal changes be made with aligners? The reality is it's a mixed bag. Yes, minor skeletal changes can be made with aligners because you're regrowing bone, but but to have major skeletal changes, that's beyond the scope of 6-month smile aligners and aligners in general. The next question is, how predictable is this case for class 2 div 2 cases? The answer is very predictable. If you want to just treat the class 2 div 2 condition but have a class 2 finish, if you must improve the class 2 and try to get it towards a little bit more of a class 1 finish, then there is literature shows, and borne out by our experience as well, is that perhaps half a division of so, again, this is very case dependent, can be improved. However, our experience in treating hundreds, if not thousands, of class 2 div 2 cases is that adult patients are very happy finishing with a class 2 because they are so overjoyed with having straight teeth that the class 2 situation doesn't really bother them. Does the dentist need to be a 6-month smile provider send cases? The answer is yes. To send cases to 6-month smiles, you have to be a trained 6-month smile provider. However, we do offer training online, and it's as little as 3 hours of your time to complete the training online. Is this available in Canada? What lab do I need? Answer is yes, we are available in Canada. So if you're joining us from Canada, welcome. You can just navigate to 6monthsmiles.com and become a provider. You do not need a lab. All you do is send us your impressions or scans and photos, and we go from there. And we have hundreds, if not thousands, of providers from Canada as well. The last question is, can you repeat how much can you intrude or extrude a maxillary or a mandibular molar? The intrusion of a maxillary or mandibular molars is, it depends on the position of the molar itself, but generally speaking, it's not a very predictable movement if you're trying to intrude or extrude posterior teeth. Typically, intrusions are harder than extrusions. The limit for intrusion is about 0.5 millimeter, and extrusions, I would have to guess. I'm sorry, I can get that question answered to you specifically. It may be better, Dr. Blauswern, Peter Blauswern, if you send to us a specific case with photos and we can advise you. So having said that, thank you for your time and your attention. We do appreciate you. If you have any future questions, you can reach out to 6-month Smiles and ask for a clinical guidance, and we'll be happy to answer your questions. So this is not the end, and so we're here, and we'll be happy to help you with any future inquiries that you may have. So once again, from the bottom of our heart, thank you for investing your time in learning more about our system and taking part in our webinar.